Buenos días a todas y a todos. En primer lugar, pues deciros que lógicamente es un placer como director del Instituto estar aquí esta mañana para presentaros a una persona pues, de una gran relevancia en el ámbito de la toma de decisiones y en el desarrollo de políticas basadas en evidencia investigadora, en evidencia científica, lo cual es algo que de cara, por supuesto, a la sostenibilidad y a la racionalidad y hacer que nuestros sistemas sean perdurables, sean sostenibles y sean racionales, pues es tremendamente importante. Como nuestro anfitrión es angloparlante, pues le presentaré en su lengua, aunque, bueno, según él comentaba, tiene un casi perfecto castellano con acento argentino, el cual se entiende bien. It's a pleasure to introduce you, our guest speaker today, Dr. John Lavis. He's the director of the McMaster Health Forum, co-director of the World Health Organization Collaborating Center on Evidence-Informed Policy, associate director of the Center for Health Economics and Policy Analysis, professor in the Department of Clinical Epidemiology and Biostatistics, and associate member of the Department of Political Science at McMaster University. His research focuses on how to support the use of research evidence in health policy making, both in high-income countries and in a broad range of countries. He founded and continues to direct the McMaster Health Forum, an agent of change that empower health systems, policymakers, and stockholders to set agendas, table consideration, and communicate the rationale for action effectively. He holds an MD from Queen's University and Master of Science from the London School of Economics and a PhD in Health Policy from Harvard University. Today, Dr. Lavis is going to give a lecture on supporting the use of research evidence in health organization and system. Thank you, Dr. Lavis.
Thank you very much. Thank you very much, Director. It's a pleasure to be here. I have maybe about 30 minutes of slides, and then I'm hoping the rest of the time, which should be about another 30 minutes, we can open it up to questions. So you'll see I have a number of questions for you at the end about what this means for Spain and what you think some next steps could be. So this is maybe a little bit hard to read from the back, but on the left side at the top, it says sub-individual levels. So that's where the biomedical research happens. Huge amounts of that happening right here on the campus of the Instituto de Salud de Carlos III. In the middle, you'll see individual level research. That's the clinical and behavioral research. A lot of clinicians doing research part-time or researchers not trained as clinicians doing clinical research. Does this or that drug work? Does this or that clinical service work? Then we move over to the societal level, where we're intervening on groups and populations. Very different, but complementary. And then down below is an area that we've seen a huge explosion of research in most countries over the last 5 to 10 years. People coming to the conclusion that we don't just need to know which drug works, we don't just need to know which immunization works, we need to know how do we get the right mix of programs, services, and drugs to the people who need them. You can have the best drugs in the world, and they mean absolutely nothing if you can't get them to the right people in a way that's responsive to their needs. And that field we tend to call health systems research. And then you'll see a bubble in the middle, health policy research, because we need to be making decisions about which clinical interventions we support in the system, for example, which drugs we add to the formulary. We need to be making decisions about public or population health interventions, which immunization campaigns are we going to be running, and we need to make decisions about how we're going to organize care. Are we going to have primary care delivered only by physicians or by teams of physicians and nurses and pharmacists and other practitioners? So the policy piece is in the middle. Our group in particular focuses more on the health systems piece, but I'm going to be talking generally about how we use evidence in all of those domains, but I'm not going to be talking about the biomedical piece. 25 years from now, that research might transform our world, but for the time being, any piece of biomedical research isn't meant to be acted on. It might flow into the world of clinical research, we don't know. I'm focused on the world of clinical, population, and health systems research that's ready for action. There's many target audiences for research, so you could have a plan to use research evidence to inform citizens, and by that I mean healthy individuals, I mean patients, I mean caregivers. So here we might be supporting them to make healthy choices about their own behaviors, to eat better, to take more physical exercise, to use less tobacco. Or we might be helping them to make better self-management decisions. So I'm living with diabetes. How can I do the best in managing my condition over time? We can also support clinicians to use research evidence. We can help nurses, physiotherapists, doctors make clinical decisions based on the best data, evidence, and guidelines. And some of you will know the famous triangle that some people at McMaster, when they first came up with the notion of evidence-based medicine, talked about. So we want the best evidence in the world, we want patients' values and preferences, and we want clinical acumen, clinical understanding of the situation. And those three together make for very good decision-making. So evidence is one input along with the other two, patient preferences and clinical experience. But what I'm going to talk about today are the target audiences of managers and policymakers. So people running hospitals, people in ministries of health in the autonomous communities, the people that are making big decisions, whether they be big decisions about clinical issues, about population health issues, or about health system issues. So I'm going to be talking about how do we support the use of evidence in those kinds of environments. And I guess I'll tell you from the beginning that I'm biased. I think, and we've been working in this area now for about 12 or 15 years, that the biggest opportunities for improvement lie in helping those individuals find and use pre-appraised and synthesized research evidence. So you don't want them necessarily to be going to Medline and finding 50 million single studies where they don't know if they're high or low quality. You want them going to places where the evidence has already been synthesized and it's already been appraised. So they look at that systematic review and they know whether it's of high or low quality right away. And then they have to ask the question, does it apply in our setting? Because the systematic review might have looked at studies from Germany, from Australia, from Canada, from other countries, and not in Spain. And you have to ask the question, would we get similar results here? And when we're looking for that evidence, we're not just looking for the evidence that tells us should we use this or that policy intervention. We also want evidence that tells us about the problem and its causes. Do we understand what the real issue is in the system? We do need evidence about the options, and we need evidence about how we implement any option that we pick. And I'm going to talk about this with a particular example. So many countries around the world, Spain like them, have high and rising rates of non-communicable diseases and high and rising rates of risk factors for those diseases. So a good senior policymaker, a good senior decision maker in a health organization is going to say, well, what are we going to do about this? How are we going to deal with this challenge? And they're going to ask good questions like, is it because we haven't put enough time and energy into addressing the determinants of non-communicable diseases at the population level? We need to be doing more with the built environment. We need to be doing more with reducing salt intake in restaurants, all of that kind of stuff. Or is it that we haven't been putting enough effort into helping Spanish citizens make informed decisions about their diet, about physical activity, that should say physical, not physician, about tobacco use? Or is the problem at the level of the health system? So it's not the big population interventions, it's not the individuals, it's the health system isn't doing enough to support the proactive, coordinated prevention and management of non-communicable diseases. And if they think the problem lies there, then a good manager, a good policymaker is going to say, well, why is that? Is that because there's no accountability at the primary care level for adhering to guidelines? So we have fantastic guidelines out there. Is it that no one's adhering to them? Is it because we don't have financial incentives for achieving targets at the level of the individual practitioner or at the practice level? Or is the problem because we have no model for team-based professional care, and if we did, we'd have much better control of non-communicable diseases? Or is it that we don't use audit and feedback? So nurses and doctors and pharmacists think they're doing a great job, but we're not giving them feedback about how they're doing to point out that there's a disjuncture between what they're doing and what they should be doing. So the problem could be at any of those levels. If we then want to make a decision based on evidence, alongside all the other factors that we know will influence decision-making, we might then say, well, what can we learn from other countries that have systematically studied the causes of high rates of non-communicable diseases? And that would mean using research evidence. What's the relative importance of citizen, clinical, and population-level causes? Or if we're most worried about the clinical level, is the cause primarily one of governance-related issues? Is it about financial issues? Or is it about delivery issues, like are people working as part of teams? And then a good manager or policymaker is going to need to know, well, where would I go for that type of evidence? How do I know what other countries in the world have done and studied and found to be the most important causes? Well, nowadays, you would go to a place called Health Systems Evidence. Every systematic review in the world about health system-related issues, all sitting in one place, all pre-appraised. And the good manager and policymaker just needs to know if my question's in that area, I should go there. Now if we move on to options. So now a good policymaker or manager is saying, okay, there's stuff happening at the individual level, there's stuff happening at the population level, but I really want to improve care. I want to improve primary care, the prevention and management of non-communicable diseases. Should I use pay for performance to achieve targets? They're doing a lot of that in the United Kingdom. I hear they're doing that in Germany. Should we be doing that in this autonomous community? Or should I be promoting a model of team-based interprofessional care where I get nurses working alongside physiotherapists and doctors and pharmacists? Or should I be putting in place an audit and feedback mechanism? So same thing. Well, what can I not learn from other countries who've tried these things and evaluated them rigorously? And again, all the evidence sitting in one place, health systems evidence, every systematic review about benefits and harms, every economic evaluation about cost effectiveness, every systematic evaluation of process evaluations that tell us how and why the option works, every systematic review about stakeholders' views and experiences with the option, all sitting in one place, all pre-appraised. So the busy policymaker and manager knows up front, is it high or low quality? And then implementation considerations. You could make the best evidence-informed decision in the world, but if you don't implement it effectively, you're not going to have an impact on citizens' lives. So what barriers might come up if we choose the option of team-based care? Well, we might come up against restrictions on some professional group scope of practice. So maybe nurses in Spain, their scope of practice is much more limited than the scope in other countries that have very good interprofessional models. Or it could be we have no payment mechanism in this country that is focused on groups as opposed to individuals. Or we might have no continuing professional development for team-based care. We provide training for doctors to work, nurses to work, physiotherapists to work, and we provide no training for those people to work together as part of a coordinated team. And then you might say, well, depending on which of those barriers are most important, which strategies should we put in place? So we might say, well, we're most interested in small group, interactive, continuing professional development training. And again, all of that evidence is going to be sitting in one place. And you'll see on average, if you use small group, interactive, continuing professional development, you get about a 4 percentage point improvement in whatever the target behavior is. If, on the other hand, we were to use audit and feedback, you can get as much as a 16 percentage point change. So this evidence more and more is sitting there, ready to be used by senior managers, senior policymakers making tough decisions about care and about systems. So you can tell me when I open it up for questions how you would assess the current situation in Spain. We are running studies in about 40 different countries like Canada, but also countries like Uganda. And what we find is that people are doing what I've just described some of the time. They're doing it for some steps of the process. They're usually, unfortunately, using Google, which I used a lot in the last few days to find great restaurants to go to in Madrid, but I would not use it to find pre-appraised research evidence. They might be doing it with a focus on what other countries have done, not what they've evaluated rigorously. So they heard that the United Kingdom was using pay for performance, and they said, oh, well, let's try that here. But they didn't look to see what the United Kingdom has found when they evaluated their pay for performance scheme. Knowing what the United Kingdom is doing is useless information. The question is, what have they evaluated, and what do those studies tell us about pay for performance? And when people look for research, they're often looking for single studies, which is just terribly inefficient, and it's sometimes harmful. So in Canada, we have only not-for-profit hospitals. There was one politician who was always holding up this one study that showed it was better to be treated in for-profit hospitals. So some researchers went out and did a systematic review, and it turned out there were 15 studies in the world that looked at for-profit versus not-for-profit. 14 of them showed it was always better to be treated in a not-for-profit hospital. Always better. And the reason why there was an outlier, one study, was because of how they did the statistical control. So you need to see all the evidence in one place, not just the single study. And if people are doing this kind of comprehensive thinking through of problems, options, implementation, they're probably not doing it also by engaging a broad group of policymakers and stakeholders in thinking through what does it mean for Spain. So a question for you is, do you think in Spanish health organizations and Spanish ministries of health, people are systematically and transparently finding and using pre-appraised, synthesized evidence to better and more efficiently understand problems, understand options, understand implementation considerations? And this can be done kind of on a sliding scale. You can do this in 5 minutes or 5 hours or 5 weeks. So time is not a good excuse nowadays, given these tools that are available to people. So another way of saying this is, do you think people in health organizations and ministries of health in Spain have the right knowledge to use evidence to inform their decisions? Do they know the questions to ask about the problem, about options, about implementation considerations? Do they know the right type of evidence to answer those questions? So if my question is about benefits and harms, do they know what an effectiveness study looks like? Say a randomized controlled trial or an interrupted time series. If they want to know how or why an option works, do they know what a process evaluation looks like that looks at how and why a particular intervention like pay for performance works? And maybe most importantly, do they know where to go to find the right type of research evidence? Because if they're going to Google, which a lot of our work in ministries around the world suggests they are, they're not going to the right places. It's a terribly inefficient way to find evidence. So if your question is about a clinical issue, this or that program, this or that service, this or that drug, then if I were you, I would go to a database called Access. All pre-appraised studies and reviews addressing a full range of questions sitting in one place. If your question is about the effectiveness of public health programs, I would go to a different, I would go to health evidence. If your question is how do we strengthen the health system or get the right mix of programs, services, and drugs to people, I would go to health systems evidence. So nowadays, people need to know if this is the area where my question is, then I need to go to the right place to find the right evidence. And when they go there, they're going to find quality ratings, and the most commonly used one is AmStar. They need to know what that means. What does 11 out of 11 mean? What does 1 out of 11 mean? And they need to know questions to ask about local applicability considerations. So you can have the best evidence in the world, but it might all come from health systems that function very differently from how the health system functions in Catalonia or this particular autonomous community. And they also need to have the right attitudes about this work. They need to know that this is iterative. You look for a bit of evidence about pay for performance. You go back and think about what's going to be politically feasible in our country. You look for some more evidence. You come back and you have some more conversations. It's an iterative process. And when they're doing it, they need to know that they're working in a political environment. So if you're in a hospital in Spain or a Ministry of Health, that's a political environment. There are people there that are appointed. They're not necessarily there because they're the best trained person to do something. And those people need to juggle the political realities, the institutional constraints, the interest group pressure. The doctors are going to push back. The nurses are going to be unhappy. They're going to have to deal with values. What's possible in the national government right now with a conservative government is different from if in November you find you have a different government in power. So people need to be looking for evidence while they're aware of all of these other politics that are happening around them. They also need to be systematic and transparent in finding and using evidence as one input into decisions. Someone should be able to go up to them and say, where did you get this? Why are you coming and telling me pay for performance works? Because when I look at the systematic reviews, I find very little evidence suggesting pay for performance always works. So tell me how you found the evidence that you've brought to the table. They also need to be able to, I think we'll skip the update. Now, this is going to, I want to pick postponer, but it's not giving me the option. What should I do? I lose either way. I either lose my presentation or...
No, I will try to, because there is no other option here.
Everyone's saying no,
todos no. Pero no hay otra opción. I don't know.
Can we just move it out of the way? Yeah, there we go. Super. Great. Perfect. Just like a politician. Just get it out of the way. We'll forget it's even there. So the next thing is finding and using the best available evidence in the time you have available. So the standard for the busy policymaker that has 5 minutes is going to look different from the person who says, no, we have 5 weeks to think this through. But that's the reality in political environments. And we need to look first for that perfect match. We're trying to figure out how do we improve diabetes management in primary care. And maybe we don't find something specific to diabetes management. Maybe we find things related to hypertension management and other conditions. So if we found the perfect match, we would call that an instrumental use of research. We're using the research very instrumentally to solve a problem. But if we're looking at a general body of research, then we sometimes call that a conceptual use of research. We're using it so we think differently about a problem and its causes. And lastly, we should be looking for our leaders to set clear expectations for others about what to ask and where to go for evidence, and encouraging their use of related tools. So good leaders in health organizations and ministries of health in Spain should be setting clear expectations for people that this is the new standard in organizations and systems around the world. No system has enough money to do everything for everyone. The question is, how can you use evidence to try to make those choices more informed by what we've learned from other places around the world? And then finally, do they have the right skills? Do they know how to clarify a problem? Do they know how to frame options? Do they know how to think through implementation considerations? Do they know in 5 minutes how to search health systems evidence or health evidence or access? I've put in brackets using Amstark because nowadays almost every systematic review that's out there has already been pre-appraised, so we don't need them to do that themselves. But they do need to think about local applicability. So if all the evidence in the world was done outside of Spain, they need to be able to think through how likely would we be to get something similar if we tried in one of our autonomous communities. And then they need to be able to commission research to fill gaps in research. So now I'm going to switch gears. If that's where we're hoping to get to, that our senior leaders set expectations for people so that they know how to find and use evidence alongside all the political factors that we know influence decision-making, how would we go about getting them there? So I'm going to draw on lessons from my own country, Canada, but also from these 40 countries that we've been studying now for about 5 years, that again range from all different parts of the world: Argentina, Chile, Uganda, many different countries, including Canada, Lebanon, many others. So lesson 1, be clear about your aim. So if you're trying to get to a place where people in health organizations and systems in Spain are using evidence as one input into decision-making, that means using the best available data and evidence systematically and transparently in the time available. And again, how that looks when you've only got 5 minutes is different from when you have 5 weeks. And you need to be looking for evidence about the problem and its causes, about options to address the problem, and about ensuring the chosen option gets the optimal impact, so the implementation piece. And you need to be doing that recognizing the political realities. The next thing that you need to think about doing is picking locally appropriate ways to get there from a workable list. So we now know from watching these 40 countries around the world what's on that list of what people think is highly promising. And so the real difficult question is not what's the list, it's which of those pieces on the list would make sense for this country. So the list includes sending signals that research evidence is valued as a key input to the policy process, or if you're in a health organization, to the decision-making process. So it's trying to improve the climate for researchers. So do you think that that exists right now? Do you think in health organizations and systems in this country that people place a large amount of emphasis on evidence as a key input into decision-making? And if the answer is no, then what are you going to do about that? 2, we need to be producing and synthesizing relevant research. So a lot of the research that's done on this campus is driven by investigators' personal interests, and that's great. But we also need to know what are the priorities of managers and policymakers in the system, and we need to answer their questions. And their questions are often different from what the researcher is asking. And then the next area is that we need to make research evidence easy to use. And some people call this knowledge translation. And there's a couple of pieces to it. We need to communicate it effectively. So the jargon is we need to package it, and we need to push it out to the people who can use it. We also need to make it available when policymakers and stakeholders need it and in the form that they can use. So here the jargon is facilitating pull. We need to make it easier for them to reach into the research world and pull out what they need in those 5 minutes or those 5 days or those 5 weeks. And we also need to prompt them to use research in decision-making. If a political decision comes down, we're going to provide support or drugs or whatever it takes for people living with hepatitis C. People are going to be running around saying, well, okay, what are we going to do, blah, blah, blah. But there needs to be a mechanism that prompts them to stand back and say, well, what does the evidence tell us about the best way of meeting the needs of people living with hepatitis C? And finally, we need people convening policy dialogues where health system challenges can be worked through with key stakeholders who are informed about the best available evidence. So governments all the time, health organizations all the time talk to people. What does the medical association think? What does the director of medical affairs think? But it's not necessarily informed by evidence, and it doesn't get everyone sitting around the table at the same time. So the doctor's not allowed to say something ridiculous about nurses or the physio is not allowed to say something ridiculous about patients without all these other people calling them on the appropriateness of that comment. So that's what the list looks like in most countries. What Uganda pulls off that list looks different from what Canada pulls off that list. So I'm going to give you an example of what we've done. So sitting in Canada, dealing with ministries of health at the provincial level and at the national level. So first, we put in place a one-stop shop, health systems evidence. So we now have more than 10,000 registered users around the world. About 40% of them sign up to receive a monthly evidence service. So if every month you want to know what is the latest synthesized evidence, the latest economic evaluations that have to do with the role of nurses in the health system, you simply sign up, tick nurses, and all of that evidence comes to you once a month. But you can do the same for pay for performance, you name the topic. We also provide a rapid response service. So people in health organizations and systems in Canada can call us up and say, you have 3 days, we need the best available evidence on what a good program looks like for people living with hepatitis C. Or you have 10 days and we need the best evidence about how to strengthen primary care. Or you have 30 days and we want to know how to give citizens a better voice in the governance of hospitals. And we pull the best evidence that we can together in that time. We also organize stakeholder dialogues informed by evidence briefs. So we get a call from someone in the system saying we're really struggling with how we get advanced practice nurses playing a bigger role in the health system. Can you help us think this through? We prepare an evidence brief that works through the challenges, options, implementation, and then we bring together all the players to talk about what does it mean for our system at this moment in time. And we've done 33 of these until now. We've also now started citizen panels because we find it very hard to get a citizen into these stakeholder dialogues and able to speak. What we often end up with is what we sometimes call professional citizens, the same person living with HIV or the same person living with diabetes that is at all the other meetings. So with citizen panels, we try and get ethno-culturally diverse, socioeconomically diverse groups of citizens together, informed by a citizen brief, to talk through issues and to try and understand what values do they think should be driving the system. And then finally, we run something called Health Systems Learning, where we train people working in health organizations and systems to find and use evidence. Again, whether they have 5 minutes or 5 hours or 5 days or 5 weeks. And we've now trained about 400 public servants just in our Ontario Ministry of Health alone. So those are the 5 things that we do. We're outside of health organizations, we're outside of health ministries, but from what we can do from the outside is make the evidence easily available, respond to urgent requests, pull together the evidence and convene dialogues, pull together the evidence and convene citizens, and help people develop their capacity to do this themselves. So those are the 5 things that we can do from the outside. If I now turn to what can be done from the inside, 5 years ago, our Ministry of Health used to be, I think, the worst Ministry of Health I have ever worked with in my life in terms of using research evidence. Every single decision was 110% politically driven. There was never any effort to look for research evidence. And in 5 years, there's been an unbelievably dramatic change. And from the outside, it seems to me it's the things that I've listed here that have made a difference. Strong messages from all levels of the ministry, from the minister to the deputy minister to the assistant deputy ministers to the directors. Everyone says using evidence is a core part of our job, so we provide good advice to the senior people who make decisions. Second thing, they instituted a health system research fund. They took back all the money they'd given to centers for years, and they put it back out as a competitive call. And you had to say you would work in an area of ministry priority, and you had to hold back 25% of your budget so that anyone in the system could come to you and say, John, we're struggling with this issue. Can you help us work it through? So we have this built-in reserve capacity to address questions from the system. They run their own internal rapid response service. They do their own internal health technology assessments. The thing that I think made the biggest difference is the research evidence tool. So in that Ministry of Health, you can no longer get to the minister or to what I think in Spain you would call the Council of Ministers without filling out a one-page form. The top half of it says, how did you find and use evidence to understand the problem, options, implementation? Lower down it says, which databases did you search? So if the question was about strengthening primary care and they didn't search health systems evidence, you know they haven't done a good job. And the next question is, what type of evidence did you find? Was it systematic reviews of high quality or single studies of unknown quality? And that single step alone caused everyone to stand back and say, we're not doing this now. How are we going to get to a place where we can start to do this? And then finally, they were the ones that asked us to come in and provide the capacity building workshops. So we could have been outside for years, knocking on doors, no impact. But they made huge decisions inside, which they've sustained now through different governments, through different health ministers. They still have these things in place that mean evidence has a role at the table. And the final piece, make a sustained commitment. So we can point to many examples of direct impact on the policy process. I've just given one, a call from the Assistant Deputy Ministers, so the second most important person in the ministry. Within 7 weeks, it went to the Council of Ministers. During that time, we came up with the terms of reference for the brief, convened the steering committee, did 26 key informant interviews, wrote the evidence brief, convened the stakeholder dialogue, wrote the dialogue summary, and briefed the Minister of Health, and then it went up to the Council of Ministers. So you can do even the long version of this, the stakeholder dialogue, fairly quickly. And we see a virtuous cycle of the more evidence being used in health organizations and systems, and the more evidence being used by interest groups. So as soon as we started training people in the ministry, we started to get calls from the Medical Association and the Regulatory College for Physicians asking us to come and train them. It's wait. Okay. Oh, is it not enough power? Wow, you're fast. Thank you. And we also see now coming out more policy-relevant research. But we're still learning how to do this. So we don't have definitive answers. We just know we're seeing lots of promising stuff being done that has direct impacts on decisions. So I'm now moving into the wrap-up, so you'll have time for questions. And I'm framing this as questions for you. What would make sense for Spain? Can leaders in health organizations and systems in this country commit to send this signal regularly and to ensure their staff do this as well? So if I'm right that this isn't happening in every autonomous community in Spain and at the national level, what would it take to get these signals sent? Can Spain and its regions maintain frequently updated lists of managers and policymakers' health research priorities, and make sure those lists distinguish the short-term needs that can be responded to by an evidence brief, the medium-term needs, maybe 6 to 18 months, where a systematic review would be helpful, or the questions that maybe they're 1 to 5 years out, and we can do primary research. And can we distinguish the questions that need local studies from the ones that you're willing to rely on global evidence, the best evidence in the world? On the communication side, can groups in Spain, because I don't think I have not found a group in Spain yet, and about 2 years ago we looked exhaustively in this country and every other country in Europe for groups doing this. We found no one producing what we consider an evidence brief that works through a problem, options, implementation about managerial and policy issues. Can groups in Spain maintain a guide to sources of pre-appraised research evidence, as well as data and local studies on a website? So you're a new manager of a hospital, you're a new person in a Ministry of Health. Can you go to one place that says, here's everything you need to know about where to go for different questions? Could you imagine one or more groups in Spain setting up a rapid response unit so people can call up and say, you have 3 days, I need the best evidence in the world, and if you can't answer in 3 days, we're going to go ahead without you. And can we find one or more groups in Spain that would coordinate capacity building to raise the skill level, improve the attitudes, raise the knowledge level among people in health organizations and systems in Spain about finding and using evidence? Next, can you imagine putting in place that tool? Could you imagine a scenario in each autonomous community and at the national level where you cannot get to the minister or you cannot get to the CEO of a hospital without simply filling out this form that says, here's how we found and used evidence, 3 bullet points, here's the databases we searched, here's the type of evidence we found. It takes 2 to 3 minutes to fill it out, but it might take 5 minutes to 5 hours to do the searches, depending on how much time you have. And can you imagine groups in Spain convening stakeholder dialogues? When we first started to do this, our government doesn't like other people talking to stakeholders. That's their job. They speak to stakeholders. But once we started to do it, they actually found it to be hugely helpful because we put evidence in front of these people, brought together a very diverse group, and then brought back the key messages from that. And then my final question for you is, if I'm right that a lot of this isn't yet in place in this country, where would you start? Would you start with capacity development so that people come to realize that this is doable, it's achievable, it should be the standard? Would you start with the strong signals? Is the problem at the leadership level that people aren't demanding this as the minimum input to decision making alongside all the political factors? Or would you start with structures and resources, setting up groups, making sure they have the funds to do this? Your country, like mine, spends unbelievable amounts of money on research. If a little fraction of that money was directed to supporting the use of evidence by managers and policymakers, I think it would be transformative. So I'll come back to that question to open it up, but conclusion, using research evidence is key to finding the best way to achieve a vision, goals, and objectives set by managers and policymakers. So even if the decision was made by a politician or by the head of a hospital, there's still many ways of achieving that vision, and the evidence can help. I think the biggest opportunities lie in helping people systematically and transparently find and use pre-appraised synthesized evidence. And the world has changed so much in the last 5 years that make this much more doable. And they need to be looking for evidence about the problem and its causes, about options, and about implementation. Evidence matters in all 3 of those. And if you agree, can you consider acting on the lessons learned? Be clear about the aim, figure out what makes sense for this country or your autonomous community, work with partners who can do what can be done from the outside, either do or push for what can only be done from the inside of these organizations and ministries, and make a sustained commitment. And my final bullet point is, don't forget to keep funding the research. I'm not trying to take money away from all of the other parts of this institute, all of the researchers that are out there. I'm just saying a little bit of that money, take it and use it to support the use of the research evidence. Because if the senior folks aren't using that evidence, then you're wasting money every day on interventions and strategies and policies that are not having the impact they could have if you were willing to learn from other countries that had studied it systematically. So these are some resources. I'll go back to my questions because I'd like to hear from you about where to start, what do you think needs to be done in Spain. So over to you for questions or comments. So questions, comments. Maite is here just in case I don't understand Spanish well enough.
Hello, good morning. My name is Francisca García Lizana. I was working in European Commission as policy officer for 5 years, and then I used your recommendation in evidence-informed policies to contribute to elaboration for the e-health action plan. So I'm really happy to be here because we can share our ideas, and I can say the current agenda for research and innovation in e-health is evidence-informed oriented. So I'm really happy because, in fact, we are looking for added value of e-health services factor, community. So we are looking for an overall framework in this sense. However, my question is not for Spain, because my real framework now is Europe. Mm-hmm. But my question is more regarding to innovation and e-health, because my problem when we was working in Brazil was innovation include different aspects in the decision-making process, because systematic review are always saying we need more research.
Right.
So, in fact, the agenda for research and innovation is including we need more evidence, but what is your opinion? So, which level or how to address this kind? Because every year an innovation is changed very quickly. Mm-hmm. So we have this factor. We need short time for implementation and to define the level of the evidence. So thank you very much.
Thanks. And good point, because I focus more on the autonomous communities in the country, but fantastic that the European community is also going down this path, because that sets the framework within which countries are operating. So very important. I don't know what I can say other than that I agree with the challenge that very often, unfortunately, when people go to systematic reviews, the researchers will have concluded there's not enough evidence, we need more primary research, and that will often be the case. And hopefully people will read that and do more primary research and synthesize the evidence again. But we also need to make the best decisions that we can in the time available. And so the people who write user-friendly summaries of reviews often don't put the point in about needing more research. They say, here's what we know. So if you're making a tough decision now, we can't tell you for sure this works or that doesn't work, but this looks promising or that doesn't look promising. So I don't think we can set a standard that's universal. I think it's the best evidence that we have at a particular moment in time. But then we always are going to need more research. But managers and policymakers are also going to need to make decisions. So they make the best decisions that they can.
My name is Iñaki Maz. I'm working here in the Health Technology Assessment Unit here in the Carlos III Institute. And I understand that you didn't find information about evidence briefs in Spain or something like that, or a web page easily available. But another thing I have to say is that we have done a lot of work in the last 20 years in health technology assessment, a lot of systematic reviews, but the question is that there is a long gap, there is a big gap between the research, the work, and the use, and even for us as a researcher, one of my problems is that we don't know how they use the information, the right. Politics, and then I think it's not a problem of capacity building, because a lot of has been done. It's not a problem of even resources or money, because a lot of money has been invested in doing research, systematic reviews, economic evaluations. For me is more a problem of the transparent right. Use and the transparent way for other that are out of the system, and even for us, we don't have a feedback after our work. Right. And the question is, I don't know how we as researchers could improve this process.
Right. Yeah. So good point. I guess a couple of things. So when I think about health technology assessment, for me usually it's kind of this piece. It's trying to inform policy about which clinical interventions are used. Sometimes it's about population health interventions. Much more rarely is it about the health systems piece, although I know in theory health technology assessment people say that you're doing technology assessments also about how we organize ourselves, which is the health system. So, and point taken, there are similarities, of course, between an HTA report and an evidence brief. And I should have said that we found no evidence of people producing evidence briefs about health system-related issues, and we explicitly excluded health technology assessments in our review. This was in a book we did for the European Observatory. But point taken, there's a lot to learn from the HTA experience. And your last point was about...
Improve transparency and...
Yes, yeah. So, it's awkward to know whether to do this, but it would be perfectly reasonable, it seems, if people are not being systematic and transparent, you're doing all of this work, it's not being used, to audit, essentially, decisions and compare them to what the HTAs say. So we did that for the World Health Organization in two ways. One is we interviewed all the senior people in the World Health Organization about whether they were using evidence when they were developing guidance. And secondly, we did an audit of all of their recommendations and compared it to the evidence. Both of those studies suggested at the time WHO was not using evidence in its guidance at all. And sometimes they were saying go in this direction, and the evidence was saying go in the opposite direction. On the day that our study was published in The Lancet, the Director General of the World Health Organization, Margaret Chan, issued a press release saying we're completely overhauling our guidance development process, because we essentially, in English, we say name and shame. So we named the World Health Organization and shamed them by pointing out how inconsistently their guidance lined up with the evidence. So if you're not getting anywhere in getting senior leaders to use your evidence, one thing you can do is a study that compares their decisions against what the best available health technology assessments do. It's not necessarily good for your career, so it might be good to have people outside the country do it, but that's one thing that I've seen used. Uganda did that very successfully to make the case for moving in this direction. We've done it to some extent in Canada, but it's dangerous. But point taken that it's maybe not about the money, it's about the leadership and the commitment to being systematic and transparent.
Thank you very much for your presentation. I was really impressed about the changes in your country, mainly with the policymakers. I'm Yolanda Agra. I'm the head of department of the Patient Safety Department in the Ministry of Health. Okay. And also I'm working with my colleagues that are in charge of quality of care. So we are accustomed to review all the evidence, maybe not all the time in the structured way, as you said, but we work sometimes with Cochrane collaboration. And also we follow, of course, the recommendations of WHO and other organizations. I think one of the problems we have is that we should push more to prepare more the professionals, to give them more training. But this is a minor problem. Our problem mainly, I think, are the policymakers. So for this reason, I was very impressed about the changes in your country. And this is a cultural change, and I have a question for you. How did you do it? Because I don't know how to do that.
Well, I can assure you it wasn't me. So there was an individual, I think this from the outside, what I saw. So our system has the minister, who is an elected politician, then a deputy minister, who is a neutral public servant, and then a set of assistant deputy ministers. And there was an assistant deputy minister for strategy and policy who came in and who took it on himself to make these changes happen. He came in and he said, I will do everything you ask me, but I am also going to completely change the culture of this organization, and I'm going to institutionalize the changes. And the minister bought the argument, and they institutionalized it. So you can't get to the minister or to the Council of Ministers without filling out this tool, because that became an official way of doing business. If you want to move into leadership positions, you have to go through some training, and that's the training that we provide. So they did somehow get a very good leader to go in, to build the case, and then to think about, in this ministry, how do we institutionalize it so it becomes the normal way of doing things. But as far as I can tell, anytime I've seen this kind of transformation in a ministry, it's been one or more visionary leaders who are very strategic in figuring out how to build the case and then how to institutionalize it. Other questions or comments? And if I'm wrong and you think Spain is doing this already, tell me, because I'd love to come and study what you're doing.
Si alguien quiere preguntar en castellano, también podéis preguntar en castellano, porque entiende castellano, aunque no hemos conseguido que hable castellano, pero entender os entiende. Digo, por si os es más fácil el diálogo con él en castellano.
Questions, comments, things you disagree with? While we're passing the microphone, one quick comment. With the Cochrane collaboration, fantastic initiative. I'm involved in the Cochrane collaboration in Canada. Just remember that it's focused on systematic reviews of effects. So that answers the question about benefits and maybe the harms of options. It doesn't help you understand problems and their causes. It doesn't answer the other questions about options, like how and why an intervention works, stakeholders' views and experiences. And so you just need to keep in mind it's an excellent resource, and maybe about 20% of the systematic reviews in health systems evidence are from the Cochrane collaboration, but it's answering some of the questions, not all of them. But sorry, there was a question.
Try in English. First of all, congratulations by your outstanding performance. And I'm José Luis Llopis, professor at the university here in Madrid. And I would like to know if you agree with the student doesn't have any skills for looking for the best evidence. So we're trying to help them and trying to construct tools at the virtual campus with assessment, with self-evaluation, and frequently asked questions. So super. I would like to hear your advice in that area. You can make some advice at this point to improve their skill, and if you agree also that they are the key point for all this. Thank you very much indeed.
Yeah, no, it's a great point. And it sounds like you're ahead of us on this front. Our students are not well trained in doing this, and we, even in our ministries of health, when we first started to provide the training, people would say, oh, but we even have a PhD who works in our unit. But a PhD-trained individual may have absolutely no training in how to find and use evidence in the way that I'm talking about here, knowing the right question, which database to go to and whatnot. So I agree 110% with you that if we can be training future generations of students to know how to do this well, then over time these changes are just going to become the norm. And in Canada we do a terrible job with this. So I teach at McMaster in a Bachelor of Health Sciences program in addition to some others, but it's the most competitive program in Canada, the most applicants to positions in the entire country, unbelievably gifted students. They come to my third-year class. They have no idea about any of this stuff. They've never heard of the Cochrane collaboration, never heard of health systems evidence, don't know the questions to ask. So in my class, it's compulsory that they learn this. They have to go through an online training module. They have quizzes about it. They have to use it in the briefing notes that they prepare. But in the whole rest of the university, there's absolutely no exposure. And there's not even at McMaster exposure for physicians, for nurses, for any of the health professionals in their training. It's just not part of what is considered a priority. So if you have suggestions for us about how to do this, we're very open to hearing them because we do a terrible job. Other questions or comments? I'm sure there's things that I said that you disagree with vehemently. So let's hear what they are.
Hi, my name is Pilar Mesa. I'm a nurse in a hospital in Córdoba in Andalusia. And I'm really impressed with the transparency of all of this. And my question is about the research evidence tool. It's a very easy way to send a message. And after receiving that, do you get any feedback on what they have done with your suggestions or the research that you put on the table?
It's a great question. So there's lots of things happening that are transparent, but the use of the research evidence tool is not transparent. So I'm not allowed to ever see it. So it's an internal document that goes up to the minister's office or to the Council of Ministers, but it's confidential and no one outside sees that. So we don't know that they're doing necessarily a very good job. And at the end of the day, when the minister or the Council of Ministers makes a decision, we know they're basing the decision on many other factors. Interest group pressure, the values of their political party, many other things. So we can look for traces in their decisions that we can link back to the research evidence, but we don't have the transparency about how important the evidence was in the decision. So we might see that they went in a different direction from the evidence, but we don't know why. We might see they went in the same direction as the evidence, but that could have been for reasons unrelated to the research and more related to interest group pressure and so on. So there's transparency in some of what's happening, but not in terms of how close the decision links back to the evidence. And I guess, again, you're welcome to disagree with me. I guess part of me is comfortable with that because we live in a democracy. They were elected. I'm not. Their re-election hinges on their ability to juggle these competing demands. Where I want the bar to be set is that they explicitly considered the best evidence about the problem, options, implementation. But if at the end of the day, they as elected people chose a different path than I would have, then that's their job, not mine. But I would love to get my hands on the research evidence tools and do a direct comparison of what was done versus what the decision is, but that's not in the public domain. Any other questions, comments before we wrap up?
Tenemos una pregunta más, ¿podemos hacer? Pues muchas gracias, John, por abrirnos un poco un camino that is will be different for us. We know, you know, that we are in a difficult period because we have been an economical crisis and now we are in the election. That means more of the option now are taking just because they need the votes, not because they need the evidence. I think it's maybe not the moment to start with speak about evidence, but we have a future.
Right, but you know, it's interesting. We just did a set of 30 case studies of big decisions made in Canada in the equivalent of your autonomous communities. And the big driver of big decisions in ministries of health were ones that were made in the 6 months after elections. Because governments are elected, they have a lot of energy, they've campaigned on a platform, and they go in and they make all kinds of big changes, often in the first 6 months. So what we're starting to do now is we're offering our rapid response service to the political parties, and we're saying we will give you a confidential assessment of any of your policy proposals. So if Podemos says we want to try X, we will tell you in confidence what the evidence says. If the Conservative Party says we want to do Y, we will tell you the evidence, and then they decide whether to incorporate it in their decisions. But I agree, now is not a good time to try to influence people in power, but now is a very good time to try to influence the political parties.
Okay, we try to do our best, which I think people is not very confident about that things, but okay, we will try to do this one. And if you don't have a word for this one man who has changed the culture, you can send to us, we can try something to work in our ministry and be able to change our reality now. Thank you very much.
Super. Thanks.